I'm a neurologist with background in neuromuscular disease, and I've been in charge of a national amyloidosis referral center since the last 30 years. I've been involved in almost all the trials concerning polyneuropathy and hereditary ATTR. It's a neurodegenerative disease that's actually a systemic disease that compromises the nerves or the heart, depending on the age of onset, on the region of the world, on the genotype, but sooner or later, patients will present with both neuropathy, cardiomyopathy, and other organs involvement. So it's really a severe disease that untreated can lead to death in, let's say, in a median of 10 years, if not treated. So it's really important for us to begin treatment as early as possible and to identify the patients as early as possible. Also, I need to say that my population is comprised of young adults, mostly. Only 25% of my population is late onset after 50 years. So it's really a very impacting disease of young people. It's highly dependent on having or not having a family history. If you have a family history, if you know the disease inside your family, then it's going to be easy to track the doctor of your family and to ask him for a genetic test, and then followed by each 6 or year or 2 years, and then detect the disease as early as possible. But if you're a late onset, if you're a new case, let's say new case in the family, or you have a different presentation, not very typical presentation for this conceived mutation or whatsoever, if you live in a far region, then your journey can be really, really a problem. I still receive patients in very late stage where we cannot properly treat the patient. They are followed by a multidisciplinary team. We try to put everything together to know what's about the heart, what's about the nerves, the kidney, and whatsoever, and try to assess for the progression of the disease, if the treatment is going okay, if you need to treat or if you need to add something. So that's what we do. It's a lot of things to be done during a consultation and during the follow-up. I was presenting about a subpopulation analysis for the main trial, the neurotransfer trial, that was conducted to know for the efficacy and safety of a second generation of oligonucleotide called eplontersen, that actually is use a GalNAc ligand to promote a more efficacious receptor linkage into the hepatocyte, into the liver. So because of this, we have 20 to 3-fold more efficacy of the drug and less systemic exposure. So less side effects and more good effects. It goes inside the liver, it knocks down the production of TTR. So TTR is the protein that is mutated and can deposit in tissues as amyloid and harm the tissues and causing the disease. Results were very nice in terms of what you know as the best endpoint to measure the neuropathy progression. Let's call it NIS+7. And also in terms of TTR reduction, it was really very important TTR reduction. As I told you, TTR is not good when it's mutated and can deposit into tissues like amyloid. So the fact that TTR is reduced is very important. And also in several other secondary parameters, like primary, also like Norfolk, that's quality of life, and some functional aspects, and several other questionnaires and aspects, and neurofilament, that's a biomarker, and whatsoever. So it's a robust trial showing efficacy of the drug in several different aspects, not only neuropathy, but quality of life as well, nutritional aspects, and very important, a very safe drug if compared to this first generation of silence that we were worried about platelets and renal function, although it was a nice drug, but we need to control platelets and renal function all over the treatment. We don't need to do it anymore. So we are very thankful. This trial also was very encompassing in terms of regions of the world. So we have a huge representation from Latin America, and you know that because of social and because of lack of so many resources in terms of health, the health system, the disease can have a very bad impact. And this can influence somehow the results of the trial. But even though we had this region very well represented, the results were also very good. So I think this is a very important thing of this trial, not just representing, let's say, the best possible health systems in Europe or in US or other very developed countries, but all over the world. So the poster itself is a sub-study trying to understand better what was the effect of the treatment if you compare male and female. And I know there is a discrepancy in terms of number, more male than female, but it was random. It was like this. It was like this for the placebo group as well. And as placebo, we used a historical group from a previous study. So in 2 time points with years of gap between one and another, the same thing happened. It was really random, but it's a good thing for the drug because the disease used to manifest in a worse way in men than in women. So the fact that the drug act well on men as in women is a very good thing. And we also have descriptions of other drugs that are not as effective in male than in female. So actually, even if there is a discrepancy, it was a good thing for the results of the trial. So try to follow the families and follow the asymptomatic carriers as much close as possible. Try to identify the disease as early as possible and begin the treatment as early as possible. And of course, try to make treatment accessible in all parts of the world because there is a lot of discrepancies in drug access depending on the region of the world. And for those that you don't know because you don't have the family to follow or you don't identify them as asymptomatic carriers, then you need to work on medical education, on network, on working with colleagues to try to educate them and try to find those more atypical cases as soon as possible and treat them as well, because also other subpopulation analysis show that the treatment can be as effective as if you initiate earlier. Of course, it's better, but still there's time to treat that. There are several red flags that were described for polyneuropathy, for cardiomyopathy, nutritional aspects, and whatsoever that can be put together and can be teach to several levels of medical education.